open so any stragglers would be able to.
Oh, don't hold that.
What's that? Oh,
So, power tool in the back. Honestly, that tracks. That tracks for me.
well, I think we should get started in the interest of time. It is 2 o'clock. Welcome. So glad to see all your bright faces. I'm sure it's going to be backed up with great questions. So glad to see you again. This is a record. This is the closest we've done presentations 2 weeks apart in all the years we've been doing these. And speaking of doing these presentations, it's been a great experience, I think, for our young doctors who are making presentations. And I don't give them any real instruction except that I try to remember to tell them this is an exercise in explaining difficult medical topics in lay terms that can be understood so that we don't talk over people's head by just throwing in hard words. And I think by and large, most of them have accomplished that. What we have today, who we have today, giving the lecture, the presentation, has gotten to be pretty well known at Butterfield because she's been here so many times. You know, we rotate people through. Not everybody gets to come here, and some people come here repeatedly. She's a great example of many things I'm really proud of. But I was going to say I think, I've got to go back and check the record while you're here. I think she's given more of these presentations than anybody else. I think this is at least her 6th presentation, and they all have been really good. And I think her presentation on osteoporosis will be also. I want to also tell you what I'm so proud of. In the 7 years, we're going on 8 years of being at Butterfield in a partnership with Butterfield Trail. So we, meaning UAMS's internal medicine residency program. That's what we represent, really. In those years, I've kind of always thought, not because it's this is, you know, geriatrics isn't a glamour field. I hate to tell you all that. Anybody agree with me? I mean, but it's a rewarding, meaningful field. That's what I've learned consistently in my career. But even at that, this year is the first year our graduating senior residents. We graduate, 9 or 10 or 11 a year. One of them. We've never had one go ahead afterwards to specialize in geriatrics until this. And she's a good influence because one of her classmates is doing the same thing. Many of y'all have gotten to know Ben Frazier. Dr. Frazier's going to do his geriatric postdoc fellowship in Little Rock at UAMS, which has a Department of Geriatrics. And Dr. Chaudhary, Abir Chaudhary, who you've come to know and is going to present today, is doing a 2-year fellowship in geriatrics and palliative care at Mount Sinai in New York, which is widely regarded as the best geriatric fellowship program in the country. So we're very, very proud of her. No pressure here, but very proud of her. And we brought along a couple of extras here today. I'm going to have to cut out a little bit early, and I've got double team here. So Rebecca Campos is here. She's not presenting, but she's here and has given a few of these presentations. She's spending this 2 weeks over at HCC as our resident over there. And then many of you know Dr. Swindell. If you don't know him, you should know Dr. Swindell. We met a long time ago. It's pushing 50 years in medical school. And in medical school, you sometimes get paired with 2 or 3 other people, and every new site you go to, you're with those same 2 or 3. Found myself with Dr. Swindell, and after a while, I said, he's so obviously smarter than me. I wish they would pair me up with someone else. And then we practiced together for a few years in Rogers back in the 80s and 90s, when he was known by a lot of the patients as Marcus Welby. And, the 2 young resident physicians don't know who Marcus Welby was. I test them on all these names, like, the common saying, adage, aging's not for sissies. You may or may not remember who said that, but you'll remember who he was when I mention his name, Art Linkletter. Art Linkletter said, they don't know who Art Linkletter is. So it's too bad, but I just don't have time to teach them everything, So with no further ado, I'm going to introduce Abir Chaudhary, who we are so very proud of.
Wow, thank you. That was a very lovely introduction. Thank you all for coming out today. I know on this most anticipated talk on osteoporosis, we had to reschedule it from February due to the bad weather, but hopefully I'm able to make this lecture worth your while. Why don't we go ahead and start with the next slide. There we go. So I thought I'd start off with a little cartoon. Yeah, so, as we get older, it's not uncommon to lose our bone density. But if you're losing them in the whole pieces like that, you should probably go see your doctor. All right, we'll get to the real stuff now. We can go to the next slide. All right, so what is the big deal about our bones and our bone health? Like, why are we always talking about this? Well, really, there's 4 main, I guess you could say, functions that our bones and our skeletal system serve. One of them is, of course, to support us. Obviously, we wouldn't be standing and walking and doing all these things without having any sort of skeletal system. And, our bones, they work in conjunction with, like our cartilaginous elements, like our ligaments, tendons, and then, they're actually moved by our skeletal muscle, so it's all part of this bigger system. And, our bones themselves, they're obviously not very flexible, or they shouldn't be. So that kind of serves as one of the ways they protect us, because they're like any sort of impact against you, they're going to be able to withstand that without any like bending that's not supposed to be happening. And I included this picture up here because I thought it was a good representation of how they really protect our internal organs. You can see our 2 lungs there, the little piece in the center, that's our heart. You can even see part of the liver and the stomach. So those are a lot of vital organs right there, and it's being protected by our rib cage. So in that regard, a very important function. Storage, you might be wondering, what do bones have to do with storage? They're actually the main reservoir for how our calcium is stored. I believe about like 99% of our body's calcium is actually stored in our bones. So it is a very important part of our homeostasis for calcium. And then that last word up there is hematopoiesis, and that has to do with our bone marrow, producing new cells. And I'm not really going to cover that in this lecture because that's its own separate topic, but still worthwhile to mention that as a function of our bones as well. Okay, we can go to the next slide. So this is kind of the overall musculoskeletal system I was referring to. Our bones are just one piece of the puzzle, but They really work in conjunction with, our joints, our tendons and ligaments, and then of course our skeletal muscle to really be able to perform all the functions that they need to. So I like to think of it as a whole system. But if we go to the next slide, we can kind of zoom in into the bone specifically. And wow, that came out kind of blurry when I enlarged this image. But obviously this is a very busy diagram, and I'm not going to talk through it, but I kind of just wanted to give you guys a feel for kind of how complex our bones actually are. I'm sure many of you have seen a model of a bone, and it kind of just looks like a piece of plastic or wood. But there's actually a lot going on within our bones at an anatomical level. And then even more so when you look at the bone composition, with our different bone cells, the matrix, collagen, not to mention all the minerals that are involved in that. So don't worry, there won't be a test on this later. Okay, we can go to the next slide. So this slide is kind of going to be the basis for our talk today on osteoporosis. There's really two things I want us to focus on this slide, if I can get this pointer to work. So this over here, called the osteoblast, these are some of our bone cells. And here, it says bone formation by osteoblast. These are the cells that are basically responsible for building our bone tissue. So that is their sole job. And then over here on this other side, you see what's called an osteoclast. So here you can kind of see in this image where there's this gap here that it's kind of eating away at the bone. And it's doing something called bone resorption. And if you're not familiar with that term, essentially it's, breaking down the bone to release these minerals, like calcium and phosphate, so that they can re-enter our bloodstream. This, again, all has to do with homeostasis of calcium, which I'm going to get to in a little bit. But I think if you can kind of understand these basic concepts, what the osteoblasts are doing, what the osteoclasts are doing, you're going to have a much better understanding of osteoporosis itself. So I actually think I have a video on the next slide that kind of shows this in action, if we can play that. No. I couldn't lecture on him if I tried.
Bone is a dynamic tissue that is continually being built, broken down, and rebuilt in a process called bone remodeling. Bone tissue is broken down and resorbed by multinucleated cells known as osteoclasts. These cells are derived from monocytes which originate within bone marrow. Osteoclasts play an important role in liberating minerals and other molecules stored within the bone matrix. Bone tissue serves as a repository for vital minerals including calcium phosphate and various biologically active molecules, such as growth factors. The release of calcium from the bone can play a role in maintaining its homeostasis within the body. The cells responsible for building new bone tissue are known as osteoblasts. Osteoblasts are thought to be derived from cells found to be associated with blood vessels. Once active, they start to produce the organic component of bone, osteoid, which is predominantly made of collagen. Minerals start to crystallize around the collagen scaffold to form hydroxyapatite, the major inorganic constituent of bone, which contains calcium phosphate. Bone mineral density, or BMD, can be used to estimate the strength of bone and to assess the risk of fracture. As osteoblasts form new bone tissue, many become embedded within the matrix and differentiate into osteocytes. The structure, composition, and cellular processes that occur within bone allow it to simultaneously serve as a calcium reservoir, while providing structural support for the vital organs and for locomotion.
So I hope that was a helpful visualization as to what I was talking about with those osteoclasts that are going to break down our bone to release those minerals that our body needs, and as well as the osteoblasts that are building back up. So like it mentioned, this process called bone remodeling, it's pretty constantly going on. You know, our bones, they don't just, you know, once they're done growing, stay that way forever. It's in a constant flux of breaking down and rebuilding. And that really has to do with going back to homeostasis of our body, which I think I have a video on the next slide too that goes into an explanation of how that works.
Welcome to another Anatomy and Physiology Smart Art video.
Hopefully this
where
won't
we
be
dive
too
into an
complicated.
important piece of art. After watching this video, you should be able to identify the hormones, organs, and homeostatic mechanisms that maintain healthy levels of calcium ions in blood. This image illustrates the organs involved in calcium ion homeostasis in blood: the intestines, kidneys, and bones. The intestines serve as the site for calcium absorption from diet into the blood. The kidneys excrete calcium from blood via urine, and bone serves as a reservoir for storing calcium. This negative feedback process can be described using these two flowcharts. The flowchart on the left shows the factors that raise blood calcium levels, and the one on the right shows the factors that lower blood calcium levels. Let's start on the left to see what happens when calcium levels are too low. When calcium ion levels fall below 8.5 milligrams per deciliter of blood, the parathyroid glands secrete parathyroid hormone, or PTH. PTH acts on three organs: bones, intestines, and kidneys. First, let's look at the effect of PTH on bone. PTH stimulates the maturation of osteoclasts. Increased osteoclastic activity accelerates erosion of the bone matrix, which releases stored calcium ions into blood. In the intestines, PTH enhances the calcium-absorbing effects of the hormone calcitriol. As a result, your intestines absorb more calcium ion from what you eat and drink. In the kidneys, PTH increases renal production of calcitriol, which not only works at the intestines, as was just mentioned, but also stimulates calcium reabsorption in the kidneys. The result is less calcium lost in urine, which keeps more calcium ions in blood. Notice that these three mechanisms work together to raise calcium levels in blood back to normal levels. What happens if blood calcium levels rise above normal? Let's turn to the second flowchart to see. When calcium ion concentration rises above 11 milligrams per deciliter of blood, the C cells of the thyroid gland respond by secreting another hormone, calcitonin. Like PTH, calcitonin acts on the bones, intestines, and kidneys. But unlike PTH, calcitonin lowers blood calcium levels. Again, let's start with the effects on bone. Calcitonin inhibits osteoclasts, but does not affect osteoblasts. The net result is that more calcium ions are deposited from blood into bone. In the intestines, calcitonin inhibits PTH. This lowers the rate of calcium absorption. In the kidneys, calcitonin reduces renal production of calcitriol. Calcium, therefore, is more likely to remain in the intestines and urine and be eliminated from the body. Subsequently, calcium ion levels in blood decrease. In summary, calcium ion homeostasis in blood is hormonally regulated by negative feedback and the organs involved are the bones, intestines, and kidneys. When calcium ion levels in blood fall below normal, the parathyroid glands secrete PTH, which brings calcium levels back up to normal. And when calcium ion levels rise above normal, the C cells of the thyroid gland secrete calcitonin to bring them back down. So what? Why is it important to understand the hormones and organs involved in calcium ion homeostasis of blood? Well, calcium is vital to numerous physiological processes, such as muscle contractions, nerve impulses, and blood clotting. Also, this knowledge has led to the development of pharmacological calcitonin, which is used as a treatment for osteoporosis in postmenopausal women because it inhibits osteoclastic activity.
Best and worst dinner for your waistline.
Okay, do you guys feel like you're in medical school yet? I know that was a very detailed video going over the mechanism of calcium homeostasis, but I feel like if you kind of have a okayish understanding of that, it kind of makes talking about osteoporosis make a little bit more sense. So yeah, now we can finally start talking about osteoporosis. So I know many of you, we've discussed it in our appointments. So what are we talking about when we talk about it? Bone mineral density. So this is gonna be what it sounds like. How dense are your bones? How many of these minerals are there? And that image in the top does a good job kind of giving you a visual representation. So on the left, that's what healthy bone looks like. It's nice and dense looking, whereas in the middle, you can see where it's becoming kind of more hollow appearing, and it mentions this microarchitectural deterioration. So that is osteoporosis, and that, like it shows on the right, is going to increase your risk of having a fracture. And so osteoporosis and osteopenia, they're basically just on the same spectrum, you could say. So osteopenia is kind of the milder form of that, and I'll tell you later on how we differentiate between the two. And then osteoporosis is going to be the more severe form of this. And next. Okay, so yeah, I did want to just kind of give you all an overview of the epidemiology and the risk factors involved with osteoporosis. So, as you could guess, this mainly affects women in a 4-to-1 ratio, so that's a lot. Most commonly, this is going to start, past middle age, so starting in your 50s, but maybe not until your 60s or 70s or beyond. And then I was a little bit surprised to see there's a higher incidence of this in people of Asian, Hispanic, and Northern European descent. I don't know why that is, but that was just a fact that I found interesting. And so, what sort of factors are going to put you at risk for developing osteoporosis? So in women, you probably guessed it, menopause is a big one, right? I think I talk about it on the next slide, but that's going to have to do with estrogen levels. Physical inactivity is actually a really big one. In order to promote good bone density, being physically active is actually a huge part of that. Another factor, if your diet is low in calcium and vitamin D, that could also put you at risk, which I was looking up earlier, what are some foods that are rich in calcium and vitamin D, and I think most of us kind of jump to dairy as the source of calcium, but there's a lot of non-animal sources of calcium that are also good. And then, smoking and excessive alcohol consumption, those are also going to put you at risk for osteoporosis. And then next, I think we'll talk about the etiology. So you can really break this down into primary and secondary. Most common is going to be primary. That's probably what all of us in this room are gonna be dealing with one day. So type 1, that is really referring to the onset of osteoporosis in postmenopausal women. So obviously, when you go through menopause, there's a big decline in estrogen. And estrogen is actually a very, has a lot of protective features that I think we take for granted when we're younger. But like it mentions here, those decreased levels, they lead to an increase in bone resorption. So that breaking down of the bone to get those minerals back into our bloodstream. And then the other type, type 2, I know it's called senile osteoporosis, but we don't have to use the word senile here. It is going to be, generally speaking, in older adults as we get older, that that loss of bone mass for a variety of reasons. Obviously, our bodies don't work quite the same as they did when we were younger, but that's probably going to be the most common that we all see. And then I did want to mention a couple of these secondary causes of osteoporosis. Drug-induced, the most common one that we see is with patients who are taking any sort of systemic steroids for a prolonged period. Say it's somebody with a rheumatologic illness that they need steroids to control that disease, but in turn they may, develop osteoporosis due to that treatment. And then, metabolic causes, issues with your thyroid, with your parathyroid, that can do it as well. And then certain cancers like multiple myeloma, that's a big one. Okay. And then I think next we're gonna talk about some signs and symptoms of osteoporosis, which, no surprise here, it's mostly an asymptomatic disease process. Some of you in this room may have osteoporosis and be completely unaware of it because you really don't have any symptoms. You don't have any anything like pain or anything that would set you off to think, oh, I must have osteoporosis. The way that most people find out they have it, they sustain something called a fragility fracture, and basically what this is, it's a spontaneous fracture that occurs from just doing like everyday activity, even something as minor as bending over. You might sustain a fracture from that, and even that can be asymptomatic. You would think that you fracture something, it's going to hurt, you're going to feel pain. But there are so many times where, we'll get an X-ray or a CT scan of a patient for a completely different reason, and it'll just kind of incidentally mention, oh, there was a remote fracture. And when we ask the patient about it, they're like, I don't know what you're talking about. I've never fractured anything, but that's what that is. That's a fragility fracture. The most common places people get those is actually going to be in their vertebra and their spine, but also in your femoral neck and your hip, your distal radius, your wrist, and then other long bones like your humerus. One kind of sign that you'll see in some patients that might actually tip you off is this decreased height and kyphosis. If you think you're getting shorter as you age, you're not crazy, you probably are. And that has to do with, this, as we develop these fragility fractures, you may not even realize the subtleties of how that affects your spine and the shape of your spine long term. So you kind of see in this image here where on the right, you're already seeing this curvature in that upper spine. And that's gonna, obviously affect your posture and your height. But some other, surprising things that may lead to is, with with your rib cage kind of bending over, it may actually decrease your lung volume, like the way that you're able to breathe and taking a deep breath, because it's kind of compressing on itself. And then, you kind of see how the abdomen protrudes out because of the way your spine is bending. I don't know that this is too common, but some people can develop like constipation, getting full sooner from that. But this is something that we want to try to catch before you ever get to the stage on the right. Because once you get to that stage, it's pretty hard to correct that. And so I don't want to say that you'll be stuck in that position, but you may end up stuck in that position. And so next, I think we're going to talk about screening. So who do we screen in osteoporosis? It seems like it's mostly going to affect women, and obviously older women, who have gone through menopause already. So the current guidelines are to screen all women over the age of 65. We also will screen women under 65 if they have an additional risk factor, such as the smoking or the alcohol use. And then if you're if you're between 50 and 65 and you've sustained any sort of like low trauma fracture, that would kind of be another tip off that we need to investigate this. Unfortunately, there is still insufficient evidence for doing these screenings in men. So that's not to say that men don't get osteoporosis. They definitely do. And kind of some of these similar clues, that occur in women, like the low trauma fracture or anything of that nature, or if it's a man that, is on steroids long term, or on men that are receiving like anti-androgen therapy for prostate cancer. That's going to put them at a higher risk for developing this. So we don't have clear-cut guidelines on that yet, but hopefully in the future that's something that we'll have a better idea for. And so I think the next slide, we're going to show you how we do the screening. So some of you may be familiar with this contraption, the DEXA scan. I know we've talked about it in several appointments. But basically this is a dual energy X-ray. I think there's two different beams that are essentially going to focus on your hips and then your lower spine. That's really where we want to look to see, is how dense the bone is there. And so I'd actually never seen a DEXA machine before. I know we have one over at UAMS, but I've not been over there to see it. So this makes it seem less intimidating to me even. So hopefully if you've ever had any reservations about getting a DEXA scan, this makes it seem less scary. It's literally just an X-ray machine. Yeah, it's open. It's not like a CT or MRI where you're in a donut. It's nice. Okay, and so then after you complete your DEXA scan, the radiologist takes a look at it and generates a report. So I have that on the next screen. So some of you may be familiar with this format. This is just an example copy I found on the internet. But basically, yeah, it shows your spine there, this graph of your bone mineral density as we age, and then this table over here, which has several different values on it. We as physicians, the one that we focus on is called the T-score. And so on the next slide, I'm going to show you what those mean. So the T-score itself, this is just the difference in the standard deviation between the patient's bone mineral density and then that of a young female that we use for reference. So looking at those T scores, anything from -1 to 1 is going to be normal. That means, you don't have osteoporosis or osteopenia. I guess greater than 1 is a high bone mineral density, which we don't usually see high. We usually see low. So if your T-score is between -1 and -2.5, that puts you into the category of osteopenia. So you have low bone mineral density, but it's not at the lowest stage. That is if your T-score is less than -2.5. That is the cutoff for osteoporosis. And so when we're looking at it, that's how we determine it. And I know at least a couple of you have brought these reports in and asked us to look at the numbers, because the impression, that statement that the radiologist puts on there, it sometimes doesn't always align with the T-scores. So you might have a T-score of, I don't know, let's say like -1.5, and then the radiologist puts in his report, this is consistent with osteoporosis. Well, no, it's not actually. So that's why it's good to, interpret your own results sometime and not just rely on the radiologist's read. But luckily that doesn't happen too commonly. Okay, and then the last couple of slides here, we're gonna talk about treatment for osteoporosis and osteopenia. So we can go to the next one. There we go. So again, the biggest approach to treatment and even prevention really of osteoporosis is going to be optimizing your bone health. We talk about, calcium and vitamin D supplementation. The recommended daily intake at the moment is 1,000 to 1,200 milligrams of calcium and 800 to 1,000 international units of vitamin D. I know many of you get your supplements over the counter, and there's so many out there now, and you can take a look at them and see the different amounts. Again, it's kind of hard for us to factor in the dietary intake of these, because you might be eating some spinach and you don't know exactly, well, how much calcium is there in this, how much vitamin D. So this is really more so focusing on the supplementation that we take rather than our dietary intake. And that being said, calcium is one of those values that we check on our metabolic panels when you get your blood drawn, and then vitamin D is a separate lab that we can check. Most people are not going to be at risk for intoxication from these supplements. It's pretty hard to do. But if that ever was a concern, that is something that we routinely check. The next part of this is maybe one of the biggest components of prevention, as well as treatment, and that's going to be strength and balance training. We think about exercise, a lot of cardio, but doing some form of resistance training, whether that's with weights or some other activity, that's what's really gonna help you long term. And if you're able to keep that up, you're only doing yourself favors down the line. And like I mentioned earlier, if you're smoking, stop smoking, because that's bad for a number of reasons, but definitely for your bone health. Limit alcohol consumption. You don't want to do any excess. And then if you're able to limit steroid use, that will help too. Obviously, in some patients, they can't do that, or else they're, other disease they're using it for flares out of control. So it's kind of a risk versus benefit issue there. And then, ideally, if we find you in the osteoporosis category or the osteopenia category with risk of a fracture in the next 10 years, we do want to start you on medication for that. And the next slide goes over those medications. So over here on the left-hand side, we're talking about the first line recommendation for osteoporosis treatment, and that is a drug class known as the bisphosphonates. And so a lot of you are probably familiar with the one called Fosamax. That's alendronate there at the top. All of those names, they belong to the same category here. But you know, the way that the bisphosphonates are going to work, they're going to inhibit the osteoclasts. So those drugs that chip away at our bone, or not drugs, cells that chip away at our bone, they're gonna stop those from doing that. The kicker to taking a bisphosphonate is that you're gonna have to take it at least 30 minutes before you take any food or any other medications, and then you do have to sit upright for about 30 minutes after you take the pill. And the reason for that is because it can potentially cause some esophagitis. So it can kind of mess with your esophagus if you take it and then immediately like go lay down. So you don't want to experience that. And then, you know, the recommendations on bisphosphonate use, you can take them for about 5 years to really get all the benefits you're gonna get out of them. And then after about 5 years, we'll put you on something called a bisphosphonate holiday. So we'll give you a break from that, and you know, we could potentially put you on something different, you know, kind of depending on where your bone density is standing. And then looking at our non-bisphosphonates, so the non-Fosamax drugs essentially, there are many different classes of these medicines, meaning they all have a different mechanism of action here. But the reason for putting somebody on not the first line recommendation is obviously if they have some sort of contraindication to taking a bisphosphonate, you know, if for some reason they can't sit upright, we don't want to put them on a medicine that requires them to sit upright. And then if we put you on a bisphosphonate and then recheck your bone density scan in like 2 years and don't see any improvement, we may consider switching you to something else, but it's kind of on a case-by-case basis. And so some of these other medications that I listed up here, you all may be familiar with. Prolia, that's a monoclonal antibody injection, and it actually it targets a special receptor that is going to basically decrease your osteoclast activity. The teriparatide, that is an analog of PTH, or parathyroid hormone. Raloxifene, that's a selective estrogen receptor modulator. That one you may see in women who have an increased risk of breast cancer because it can help with that. And then calcitonin, that's that one that was mentioned in the video from earlier that's going to help bring down your high calcium levels. We can actually give that as a medication too. Although, is that one only IV? I think that one's only IV, so I don't know if that we can do that in the outpatient setting, but we can do it in the inpatient. And then estrogen, you know, you may be thinking, well, if the problem with postmenopause osteoporosis is the decline in estrogen, why don't we just give estrogen replacement? And that's because it carries a lot of other risks with it, you know. Giving systemic estrogen, you can increase your risk of like stroke, heart attack, blood clots. So although it may seem like it's a good idea for your bone health, those other issues are much, much worse to deal with. So that's kind of how we how we think through, what treatments to put you guys on. And then I think I have one last video just to kind of summarize everything.
Our bodies and their movements are greatly aided by the joints and bones. However, some conditions can hurt the joints and bones. We have discussed gout and arthritis, which affect the joints, in our previous videos. Now, we will talk about osteoporosis, which impacts the bones. Bone is a living tissue. It constantly revamps itself by growing new cells and breaking down the old ones. If the growth exceeds the breakdown, then the bones will improve. Like during our childhood, when our bones grow stronger, and our adolescence, where our bones grow longer and we become taller. The bone density peaks between 20 to 40 years of age. But when the balance shifts and the breakdown outdoes the growth, our bones become compromised and lose their density. Osteoporosis is a condition when our bones become less dense and become very fragile. It shows no symptoms and develops slowly in the background over the year. That is, until a common fall or simple impact suddenly breaks your bones. Unlike Paget's disease, which usually only affects a single bone or is localized in an area, osteoporosis is spread to all bones of our body. Risk factor. Women are more likely to suffer from osteoporosis, especially after their hormones change during menopause or postmenopausal osteoporosis. Osteoporosis runs in your family. A child with a genetic disorder can also suffer juvenile osteoporosis. Bad habits, such as drinking, smoking, and rarely exercise. Having a low body mass, with a body mass index less than 21. Receiving steroid treatment for 3 months. Self-help. The following advice can help you reduce the risk of osteoporosis. Add plenty of calcium and vitamin D as part of a well-balanced diet. They can be obtained from dairy products such as milk, cheese, and yogurt, along with milk made from soy, rice, or oats. Do exercise regularly, especially resistance training using dumbbells or posture training such as Tai Chi. Quit smoking and drinking if you are still doing them now. To treat your osteoporosis, you can consult with a rheumatologist. To diagnose, they would advise you on a particular test called DEXA scan for diagnosis. This test measures bone density. The possible results are normal, so the risk of a low-impact fracture is low. Osteopenia, which means that you have a small risk of a low-impact fracture, but your bone is already weaker than the average one. Osteoporosis, which is when you have a greater risk of low-impact fractures. Discuss this with your doctor as you may need treatment. This test is done before starting treatment and can later be repeated at 2 to 5 year intervals as per your doctor's advice. Treatments. Bisphosphonates, such as zoledronic acid treatment, will prevent bone resorption by binding to the bone mineral and induce apoptosis of osteoclast. Teriparatide, which is a synthetic, simpler human parathyroid hormone. It will promote the growth of the bone by decreasing bone turnover. Raloxifene, which has the benefit of estrogen hormone without its drawback, can treat postmenopausal osteoporosis. Denosumab, a monoclonal antibody, prevents the maturation of osteoclast. Treatments such as strontium ranelate are under scrutiny due to their dangerous side effects. All of them will help to increase the BMD or bone mineral density. After receiving treatment, inform your doctor whenever you encounter gastritis, which is the most common side effect, skin rashes, sore mouth, flu-like symptoms, jaw pain, headaches, and nausea. Remember, bone renewal is a slow process. Even though you won't be able to feel whether or not it's working, your bone density should start to improve after 6 to 12 months. Your doctor may suggest a break from your treatment after 3 to 5 years, but the effect of the treatment will still continue later.
Okay, so hopefully that gave you all somewhat of an idea of osteoporosis. I know it was a little bit more anatomy and physiology heavy than some of our usual lectures, but you guys are very intelligent and always ask very intelligent questions, so hopefully this helps. I guess we can open up for questions now. Yes.
One of the biggest factors you talked about was the risk-benefit analysis of what's good for you, what isn't. As you get older, you get more than one condition.
Yeah.
What if it's, dairy is recommended in for treatment of bone density loss,
Do you want to?
but dairy is not recommended for chronic renal disease.
Yeah.
How do you balance all of these things out? I mean, you say, what's more important to me at any,
Yeah,
it's just hard balancing.
it is hard, and it's really something that we have to assess on the individual basis. You know, is ramping up your calcium significantly going to help your osteoporosis? Well, if you're already at the point of osteoporosis, probably not. You know, if it's affecting another issue that could potentially be worsened by, you know, intaking much more calcium, then I think in that regard, you know, your doctor would probably recommend not over, you know, risking something like that.
So it's a question of talking it over with your doctor as
I
to
think so.
if you've got two or more conditions and the corrections to those conditions contracts
Yes.
with each other.
Yeah,
conflict with each
absolutely.
other.
Because, you know, in fixing one, you don't want to make the other worse. So it's a lot of that balance, like we talked about.
Going back there first, sorry. I can talk loud. I don't take oral steroids, but my inhalers for my asthma contain steroids. Is that as dangerous as?
That isn't.
Sorry, I was gonna.
No, go ahead, Rebecca.
The pulmonologists that we work with say there is a small risk with that,
Yeah.
but it's not as much as an oral steroid.
Yeah, it doesn't have the degree of systemic effect like the orals.
Someone up here was first.
If you're in a situation where you need steroids, what do you do to keep your bones healthy?
Yeah, that's a great question. You know, I think if it's something that you would need steroids for just like a short duration, you know, say you maybe have like a flare up of COPD and you just need to be on some oral steroids for a couple of days, that itself shouldn't affect, you know, your bone health too much. It's kind of when, you know, you're requiring more frequent doses or, you know, having to be on it for a much longer period. And in that case, you know, your doctor should be assessing your bone mineral density, you know, kind of just checking out where you fall on that category, and, you know, if you need to be on treatment, hopefully be on the right treatment, but then some of those other preventative things we talked about, you know, your vitamin D and calcium, and then also that resistance training. That's honestly, exercise is one of the mainstays of prevention here.
So you might be in a position where you could live with a little arthritis, but prevent your bones from breaking.
Yeah, because if they break, the arthritis is probably going to get worse.
Years ago, it was recommended that I take calcium citrate, that it's more absorbable. Is there more research that's been done on that?
There probably is. I haven't personally looked it up, actually. Rebecca or Dr. Swindell, do you know anything about calcium citrate versus other forms?
Well, I've heard that too. I don't know if there's a lot of evidence that really supports that, but I've heard that as well, that calcium citrate may be a little better absorbed than things. But, I don't think there's definitive evidence one way or the other. I mean, it's a matter of how well it's absorbed. I understand calcium citrate may be better absorbed at times, and so, you know, if you have your druthers, I guess, and you wanted to take that, that'd be fine. You might get a little better absorption, but I don't know that it makes a huge amount of difference one way or the other, truthfully.
Well, while we were talking about calcium, I'd like to tell you, I have osteoporosis and I'm taking it, but it scares me to death to take calcium. And I'll tell you why. I want you to tell us why. There are a lot of side effects. And one of the side effects that bothers me a lot is the calcification of your arterial system and your heart. And it's also true that too much calcium or too little calcium can be very dangerous. As a matter of fact, it can cause heart arrhythmias. So that worries me, and I don't know how to adjust calcium in order to do what it's supposed to do in terms of bone building and not get into trouble with these side effects. Now, one of the things I've run across, and I think we've even talked about it, there is something in the literature now about the fact that vitamin K will help prevent that calcification. So I wonder if you'd comment on all that.
Yeah. So again, going back to the concern of it calcifying your arterial system, that's a valid point. That's a valid concern. I think, and I don't mean to say this as, oh, you all are older, this, like, it shouldn't be a concern. But, for most of us as we age, our arteries do kind of naturally get calcified too, just after so many years of, our diet and what our genetics are doing on our body. It's kind of hard to know exactly, like, oh, well, how calcified are my arteries, unless you have maybe known heart disease where they're kind of able to assess that a little bit more regularly, with some of those more invasive testing. As far as the vitamin K component, I think you had given me an article about it one time, and admittedly, outside of that, I haven't seen a ton of literature on it yet. Obviously vitamin K is also an important component of our coagulation cascade, and when we give it, in patients in the hospital, the most common reason we use it has to do with that reason. If a patient's coagulation cascade, if something's not working there, or if we need to reverse coagulation, that's the reason that we primarily use vitamin K. Outside of that, I don't know if you have heard anything more about the use of vitamin K outside of... Okay. Yeah. I think until there's more research done in it in a much, larger randomized control trial, we won't unfortunately see it used much in clinical practice, at least for that specific indication. But I think it's, if what they found in the study you showed me, if they're able to show that in a bigger study, that would be wonderful, because it kind of goes back to that risk versus benefit conversation, right? We want to help one thing but not worsen a different thing. So you're right on the money.
Another question, please. And that is the fact that the parathyroid gland has a lot to do with this whole picture.
You're right.
But rarely physicians order it on a blood test, and I wonder why they don't do that. Discovered my trouble was a parathyroid problem. Just happened to order that blood test to show what was going on, and I had an overactive one. I mean, you might explain an overactive parathyroid takes calcium out of the bones.
Yeah, so I mean, typically we want to investigate parathyroid hormone, definitely in cases of unexplained hypercalcemia. So when your calcium level in your blood is higher than it should be, because, you know, we want to investigate, you know, is there a primary parathyroid disorder that's involved in all this? Now, I mean, you saw how complex the kind of the endocrinology behind all of these different factors come into play. And so, I mean, what other instances do you check PTH in?
Primarily, it's in patients who present with hypercalcemia, maybe some kidney stone issues, maybe affecting that as well. Your serum calcium is usually very well maintained. 99.9% of all your calcium's in your bones, so it really is not affected by what you take in. I mean, you can take a whole bunch of calcium. If you monitor your blood level, calcium levels are basically going to stay the same because it works very vigorously to keep those levels at a certain point, because if you get too much calcium in your blood and you get severe hypercalcemia, it can be fatal. Too low a calcium, you'll be tightening up and having severe spasms in your muscles. So your body tries to, and this mechanism is amazingly effective at keeping those levels normal. So how much you take in, you would have to take an awful lot of calcium in to really affect that one way or the other, because your body will just not quit absorbing it after a while and just go in one end out the other, because your body does have to have certain hormones that make you absorb that. So, but that's those levels are very, very important. So usually you measure PTH levels when patients present with asymptomatic hypercalcemia. Most of the time in the office, if somebody walks in and you check a calcium, it's 11. Well, that's interesting. So you start checking to see, and frequently it's maybe due to hyperparathyroidism. Some experts really don't just watch it for a while. They don't necessarily operate on it every time, because one, that's kind of difficult surgery. Usually an ear, nose, and throat doctor has to go in and take them out, and sometimes they're very hard to find. So you have to do special scans to try to even localize them, because frequently you can have ectopic parathyroid hormone or parathyroid tissue, maybe in your chest and around your aorta, maybe weird spots, and that may be causing that elevated parathyroid hormone level. So. It can be a challenge sometimes to even find the little buggers. The surgeon may be in there trying to find them, because they're usually embedded in the thyroid. You don't want to take the thyroid out, so you have to kind of root around there trying to find the parathyroids. And frequently there's a kind of a standard spot you normally find them, but it's not uncommon that they're not there. They've turned up somewhere else. So anyway.
And I would also just add on to that briefly. A lot of these situations where it's like, oh, well, you could test this, or yeah, you could test this, so why don't doctors order it more often? Somewhere at some point in time, somebody probably did a study on, well, what happens if we check this lab in every single one of our patients? And they probably came to the conclusion that it wasn't cost effective based on the results. So that would be my assumption as to why it's not recommended to do a routine check of it.
If a person has osteopenia, or it shows osteopenia in one or two parts of the body, does that necessarily lead to osteoporosis?
Not necessarily. So if we catch you in that category and, we get you on treatment to try to reverse that, or you do kind of some of these other lifestyle modifications, then you may never develop full-blown osteoporosis. So yeah, that's a good question. She's like our very own Vanna White.
To follow up on that, so if you get a diagnosis of osteopenia, at what point do you prescribe? You automatically just start prescribing something for that, or what point do you prescribe?
So for osteopenia, generally we prescribe medication for it if they also have an additional risk factor that's gonna, put them at a higher risk of having a fracture within the next 10 years. And there's all sorts of these like fracture assessment risk scores out there that we can use to kind of help us determine. And I think they also include it on the DEXA scan reports too. So looking at that, if you are at an increased risk for having a fracture, definitely better to get you on treatment, even if you are still osteopenic and not porotic.
Y'all can pass it along.
Two questions for you. One, if you've been on Fosamax in the past and you did the 5 years, and then you've been off for a number of years, is it advisable to go back on it if you have osteoporosis?
Yeah, absolutely. It's one that you can go back on similarly for the 5 years again.
Okay, the second question is, I was visiting with a woman who lives here. I don't remember her name, unfortunately. She said that she had spontaneous fractures. And she was put on a drug, I think by infusion, called, and I don't remember the name, Avinity, would that be right?
Oh, yeah. Avinity is, what's the generic for that one? I'm forgetting. But I've seen, or I think a rheumatologist prescribed that drug before. And if I recall, it's an infusion. I want to say they take it for like a year or something like that. I would have to look it up.
I think that's right. I think that's what she said.
Yeah, and so, again, it's just a different form of the same treatment modality. I don't know why that one was chosen in her case over a different one. That's an excellent point. He was saying that in order to get that paid for, like the prior authorization all approved for that, you probably need to get that from a specialist such as a rheumatologist.
But I noticed that treatment was not mentioned in your slide.
Oh, yes. So I didn't include the full list of all the medications because there's so many out there now. I just kind of picked some ones that we commonly see, but yeah, it's definitely a known treatment of osteoporosis.
And she said that this was designed to build bone.
Mm-hmm. Yeah. I mean, some of them, like I said, some of them are inhibiting the osteoclasts, the cells that are breaking down, and then some of them are kind of helping with that bone formation. So it's all part of that same principle. Yeah, great questions.
Anyone? I don't see any others. Oh, there's one back there. I'll come back.
So many of us are on Prolia, and I have an endocrinologist and a rheumatologist, and they pretty much tell me I will never come off it. And I have other people that say, oh, their doctor took them off Prolia. What advice are you giving?
So as far as coming off Prolia, I mean, you certainly could come off Prolia. There's not a reason that you couldn't per se, but for those that do, you want to end up putting them on something different because once you stop Prolia, you're going to get those osteoporotic changes coming back. So let's say you do Prolia for a couple of years and for whatever reason decide don't want to continue that, well then you should ideally transition to a bisphosphonate, like Fosamax or something if you're able to. Otherwise you'll kind of undo all the hard work you did.
And the other question is, when you're on Prolia and if you have to have surgery in your mouth, you're not allowed to. And I have a sister and a cousin that are faced with this. They either have to come off of the Prolia and for a couple years before they can have an oral surgery like an implant, a tooth implant,
wow.
something like that. And I wondered if you've heard of the latest advice you're giving people.
I was wondering when the osteonecrosis question would come up from our friendly dentists and oral surgeons. there's been a lot of debate over the years as to how big of an issue that really is. To the dentists and oral surgeons, it's a big deal. Truthfully, for most endocrinologists and rheumatologists, they don't see very much of it. But when it happens, it's catastrophic. It's a real mess. And so it's something that everybody wants to avoid. As far as I know, there's never been many studies really that come out. So how long is long enough? Do you stop it? Most dentists or oral surgeons I know will want you off Fosamax or bisphosphonate, any of the bisphosphonates, for at least probably a month or two. I don't know if there's any evidence that really makes a difference, but it makes them feel better. So I guess we would do it. But any of the treatments for osteoporosis, because of the way they work, can inhibit bone remodeling in the mouth. And when you have and then we're talking about major dental surgery, not just fillings and that sort of thing. But when you have they put bone grafts in your jaw to try to build it up. All these things can affect that, at least in theory. And so there's been a lot of debate about that. And you'll generally just follow the oral surgeon or dentist what they want to do, because they're not going to do it until you do it. It's kind of their ball game then. So, but there is a lot of debate about that. So, Prolia has a very long half-life. You get a shot every 6 months, so it takes a while for it to get out of your system. So they're probably going to want you to stay off of it for a while. Maybe 2 or 3 shots would be a year and a half. So before they do the surgery. So it is a concern. A lot of debate about just how big an issue it is.
It was exciting for me. I have taken Timlos, which is a daily injection, and I came out of osteoporosis in my back. I still have a little bit of osteopenia in my hip, but it was, so I just wanted to give that word of encouragement.
Oh, well, thank you for sharing. Yeah, osteoporosis, osteopenia, it's not something that you're going to feel get better, the way like a cut or a bruise, you feel it get better. But, when it works, it's fantastic. I knew there would be a lot of questions on this topic.
This is not a question. The reason my rheumatologist chose Avinity for me was because it was the only one that traditional Medicare covered.
Oh, wow.
And the price of that drug is sky high.
I bet it is. Wow. That's depressing. $3,000, wow.
Money is a motivator.
I'm a little bit curious about the fact that you always hear that exercise is excellent for building bone strength. Why is that?
Well, I suspect it has to do with regulating our body's homeostasis again, with that.
Specifically?
Specifically? Oh, I think you're testing me. And you know the answer, and I guess I don't. I'll have to think about this one.
I really don't.
I mean, from a prevention standpoint, when you do like the resistance and modeling exercises, it'll kind of improve your balance, and I would say you're less likely to fall or to do a sudden movement and break something.
That's not what you say, though. It actually increases bone strength.
Yes, I guess.
You hear it. I mean,
Rebecca, do you know?
That's always included, but I don't know why.
I know, like it always says it in our textbooks, but it never goes into the.
I have a theory.
Okay, let's hear your theory.
What I've always thought it was your weight-bearing exercises.
Mm-hmm.
You're almost increasing inflammation and bringing those, like you had the interleukins and everything come
Yeah.
into that area that stimulate the osteoblasts to
That's a good point.
bring all those cells to that area
So
of your
then
bone. That's
it's-
why they say weight bearing too.
Yeah, so it's kind of
Helps
like when
prevent it.
you like injure yourself and all the
Comes
cells
to- yeah.
rush to that.
Does that mean that water aerobics won't do the job?
Not as effectively, I guess. It's still great, and I'm sure there is, you know, some improvement with like your perception and balance, I would think, since you're doing it in water, but I'm not the expert on that.
One more thing from me. I just can't let my friends go without mentioning this because I believe totally in it, and that is eating prunes enough every day will actually increase your bone density. Yes, it does. It has been proven at several major universities, including Harvard.
And do you know the mechanism behind that one? 'Cause
Yes.
I don't.
Well, yes, it does. It influences the osteoblasts
The osteoblasts.
in a very different way.
Interesting.
But then, you can eat all the foods you want, but another diet or another condition says, don't eat prunes. So you're taking risk benefit.
Yeah, I know. I don't know what to tell you. I would say talk about it with your doctor and figure out.
I taught 7th grade science, so I'm
Ooh.
not an expert. But we got into, when we were studying bones,
Yeah.
one of the students came in and told me that his father was a doctor, and he said that they had done bone densities on pitchers' arms in baseball, and the density of the pitching arm was much higher than the less dominant hand.
Wow, that's really cool.
And so,
Yeah.
yes, it's the pull of the muscle on the bone.
That's really cool.
We should all 20 years ago.
Kidney stones. Helen, did you hear me? And she got rid of her kidney stones by having her parathyroid removed. I wasn't going to talk, but
Is that it, Dr. Chaudhry?
That's all I have, but happy to answer any more questions. Thank you all.